Okay, it's good to be here. I've only been in the UAE for 6 months, so it's really rewarding to see that there is a lot of activity going on, not only in the hematology, oncology arena, but also overall in terms of the genetic aspects. It's going to be very hard to follow Dr. Mustafa's presentation. Thank you so much for enlightening us with all these rare things. So I was asked by the chairman and the organizing committee to talk about something rare. And I just had two new cases that I thought would fit the profile. So I will talk about the severe aplastic anemia in childhood. Thank you. Okay, so this toddler came to me, I want to say right before Christmas. She presented to an outlying hospital with her second febrile seizure. She had one probably when she was 6 months of age, did great, never needed any intervention. And then this time around, she presented with fever and had a seizure. And as you probably know, part of an evaluation for any child that comes with fever, we grab a count. So she had a full CBC, which showed pancytopenia, and I will show her numbers in a minute. Due to the severity of her platelets, she received a transfusion prior to transferring. She was placed on vancomycin and meropenem because she was quite neutropenic. On examination, she only really had fever. So when Dr. Mustafa alluded to the organomegaly adenopathy, I think is very crucial when you see a child with pancytopenia to look at the physical examination. She had no skin or skeletal anomalies, which usually is something we look at in people with pancytopenia, because in the inherited bone marrow failure syndromes, people do have anomalies. So on her count, she had a hemoglobin of 9.1, which is not terribly low. Typically for a 2-year-old, you would like a hemoglobin level between 11 and 11.5. Her platelets were quite low at 18,000. And then again, we always look at the absolute neutrophil count. So not only was her white count low at 0.68, but she only had 20% neutrophils or SEGs. So she had an absolute neutrophil count of 130. So when faced with pancytopenia, what kind of workup does one do? Viral studies are very crucial. So we got a panel of these most common viruses that we normally test for. The hemoglobin electrophoresis was mainly to target the fetal hemoglobin because these tend to be elevated in the inherited bone marrow failure syndromes, since you have a return to the fetal erythropoiesis. We did a bone marrow aspirate and biopsy, and I'll talk in a minute about why you need a biopsy. And then because you want to distinguish whether this is an acquired versus an inherited form, there's a whole panel of genetic testing. And I think it is good to connect with a good genetic lab because often we do find that these people harbor a genetic disorder. So we did the diepoxy butane, the mitomycin C, you look for PNH. So that's typically the workup that we do for a child that presents with aplastic anemia. So I'm going to talk about her treatment, and then we'll come back and talk about what other treatment options are typically available. So for this youngster, I started her on a medicine called anti-thymocyte globulin. The second one in line is the cyclosporin A. We use steroids in order to mitigate the side effects that usually arise from using ATG, and we'll talk about it in a minute. And then normally there's still a debate as to would you use a TPO mimetic, whether it's the L-thrombopag or the end plate. And then we rely on the growth factors. So people have used either the Neupogen, the GCSF, or the GMCSF. And there's some debate as to do you really need to use all of them and or not. So again, when we look at what we call bone marrow failure, it is important to make the distinction between, is this an acquired event or is it an inherited one? I'm not going to discuss the right side of the column, but just to give you some of the common names that we encounter. Some of these can present with an isolated cell line depression. So severe congenital neutropenia is typically a disease of the neutrophils. Diamond blackfan anemia is a disease of the red cells, but some of those can evolve over time. And so you may begin with a one cell line, and then you may end up with pancytopenia at some point. As far as the acquired aplastic anemia to the left, often we look for medications, toxins, chemicals, viral infections, but I can tell you in my 35 years of practice, I have yet to discover a common cause, or at least an offending agent. So I think we search high and low, but at the end of the day, it is very hard to pinpoint as to what led to the development of the aplastic anemia. So what is aplastic anemia? I think we need to at least agree to a common definition. So when we say severe aplastic anemia, as our patient had, you look at the blood and then you look at the bone marrow, and there are some very firm criteria. And you do need to meet at least 2 out of 3 criteria on the peripheral blood, and then 1 out of 2 criteria on the bone marrow. So ANC, that is less than 500. Our patient was about 130. Platelet count less than 20,000. She was 18,000. And then I did not mention her reticulocyte count, but it was almost close to 0. And then on the bone marrow, it is not enough to do just the aspirate, because you can have an artificial dilutional effect. And so it is very crucial that you get a biopsy. And then we're looking at a fairly reduced cellularity, less than 25%, and hers was about 3 to 5%. Just from a academic perspective, there is a definition for very severe aplastic anemia, which is less than 200. But I really think once you're below 500, you are quite neutropenic and your risk of infection is extremely elevated. So aplastic anemia does present with an insidious onset. Some people have been able to locate something that we call an inciting factor, typically a month and a half or 2 months prior to the event. They don't usually present in a sickly way like a child with cancer, specifically with the pain that is related to bone marrow infiltration, the weight loss. They usually don't have the adenopathy or the hepatosplenomegaly. So I think the examination upfront can tell you in what direction you should go. They often present with thrombocytopenia, and even though they don't often bleed as often, however, once you're quite low on the platelet count, I think it is a setup for bleeding. MCV is typically increased, and so this is something, as Dr. Mustafa just mentioned, we look at very carefully, because if the MCV is high, then you have to think of an inherited bone marrow failure syndrome. In her case, the MCV was perfectly fine. And then you look at the evidence of return to fetal erythropoiesis, and you look at the hemoglobin F, and in her case, her hemoglobin F was normal. So what causes acquired aplastic anemia? We all know if you get radiation, that will affect your bone marrow reserve, and so people after radiation can have aplasia. Drugs and chemicals, we often use cytotoxic agents, so this is kind of oncology-induced aplastic anemia, but hopefully not permanent. So most of the chemo drugs we use will induce some sort of bone marrow aplasia. And then people have talked about benzene and alcohol, and in the good old days when people used chloramphenicol, that used to be one of the common offending agents. I often get consultations about people with seizure disorders and taking anti-epileptics, and sometimes you see a reduction in the bone marrow reserve, and people usually get a little bit anxious and ask us if they should stop the medication. And then the viruses, again, I did already alluded to the fact that we normally do a panel. We look at the hepatitis and CMV and EBV, but I can tell you that often all these investigations come back negative. There are disorders that are well known to be associated with acquired aplastic anemia. In my Fellowship book, we always talked about thymoma. I've never seen one, but that's been well described as an association. We know that some people with MDS, when you do a bone marrow, they may not be necessarily hypercellular, so you could have what we call a hypoplastic MDS, other autoimmune diseases. So whenever we look at the acquired aplastic anemia, we think in the background as to some sort of immune event, whether it is a cellular or a humoral type of immune disorder. So again, as far as the diagnostic evaluation, the biopsy is very crucial because you are trying to put a lot of emphasis on how cellular the bone marrow is. The cytogenetics on the bone marrow, because you don't want to miss an MDS that is going to require transplantation. You do rule out the inherited bone marrow failure syndromes, and there's a whole slew of genetic testing that one needs to do. You assess the PNH clone size. This is a test that we run on a peripheral blood, not on the bone marrow. So you send it for flow cytometry. And then you look at the viral panel, and then you kind of take a look at the overall health condition of the child. So when I say we often don't find a reason, we end up calling it idiopathic, even though I know with technology, one day this term will disappear because it does reflect sort of lack of knowledge on our part, as opposed to the fact that this disease does not have a known etiology. But we think there is some sort of an immune dysregulation. There have been people who went to transplant to fix their aplastic anemia, and upon receiving the chemotherapy that was the BMT preconditioning, they resolved their aplastic anemia. So some sort of immunosuppression can obviously help the aplastic anemia. So we think that there is a role for what we call the cytotoxic T cell that will inhibit normal hematopoiesis and will lead to the stem cell destruction. And hence the idea that if I can target the T cells that are causing the destruction of the stem cells, then I can remove the offending agent and then allow the bone marrow to start to work normally. And that was the beginning of what we call the era of anti-T cell therapy. So we have this concoction that we call IST, or immunosuppressive therapy for severe aplastic anemia. And there are different ways of doing an anti-thymocyte globulin. There are two products. One is horse-derived and one is rabbit-derived. Most of the literature would favor using the horse ATG as opposed to the rabbit, but some people have used rabbit. I did not have access to the equine, and so I treated this child with the rabbit ATG. The dose is different between the two products, and so for the equine, usually you like to give on the order of 150 per kilo total. So we usually do it over a split course over 4 days. The steroids are not really to treat the aplastic anemia, but to mitigate the side effects of the ATG, because these people can develop severe serum sickness. And then cyclosporin is a main ingredient. Some people have used it as a sole agent. In this protocol, we use a combination of ATG cyclosporin. You do need to stay on the cyclosporin for anywhere from 6 to 12 months. Usually once the count stabilizes for at least 3 months, then you try to wean them off the treatment. And then we are using more cytokines than ever before, because the longer the child is neutropenic, the higher the risk for severe infections. And so I have been given this toddler the GCSF, and I've managed now to keep her count reasonably well with an alternate day schedule. So she gets it every Monday, Wednesday, Friday. And then I put her on the, they call it, I believe, Revolade. We call it the L-Thrombopag, or it's called Promacta in the US. And so this is a pill that she takes, but the alternative route would be the Nplate, which is the sub-Q injection. And there are some small series of using high-dose Cytoxan. I had a child that I treated one time with high-dose Cytoxan, and that kind of helped. So it's not a common approach. So there are side effects to the ATG. So when these people come, you have to admit them. You have to keep them in the hospital a minimum of 14 days, even though the course is only 4 days, because you have to monitor for the side effects. So we gave her a hefty dose of methylprednisolone, 2 milligram per kilo per day. And then I weaned it down to 1 per kilo per day for the following couple of weeks. She had no reaction whatsoever. Serum sickness can develop, so people can get like myalgia, arthralgia, and so these definitely need to be watched very closely. You do keep them in the hospital, as I said, for about 2 weeks. And then some people, because you are depleting so many T lymphocytes, you are getting into the lymphopenia territory, and you need to be careful about what used to call the PCP, the pneumocystis, and you have to prophylax them with either Septra drug or pentamidine. But again, with the sulfa drugs, you have a concern about myelosuppression in somebody who's already pancytopenic, so I favor the use of the pentamidine. The cyclosporin side effects, again, you have T-cell inhibition, so you need to be careful with the infection from the PJP. Hirsutism, when you look at her right now, and she's been on the cyclosporin for about 6 weeks, she has developed quite a bit of hair growth. We monitor her blood pressure very closely. We monitor her magnesium because she can develop hypomagnesemia and run the risk of seizures. And then kidney toxicity, gingival hypertrophy, because they're going to stay on this medication for quite some time. So for immunosuppressive therapy, what is the data? What is the outcome? I think it works very well. When you look at the response, it's well over 80%. So people have responded very well. The question is, how sustainable is your response? And then what else could happen in the aftermath of using ATG? So we know that a 20 to 30% percentage will either have to stay on the cyclosporin or they may just relapse. It does take a while before you see the full impact of the treatment. So you're not going to despair after 6 or 8 weeks. You just need to give it some time. When we say complete response, that means everything is back to normal. Or you could have a partial response, which is not a bad thing, where your risk of infection becomes low and then you're transfusion independent. So that's what you would get out of it. The issue is your bone marrow is never normal, so you're going to always have some sort of abnormal hematopoiesis. We worry about clonal evolution. People may develop myelodysplastic syndrome. You worry about eventual AML formation, and the risk is still low, but not negligible at 10% after 10 years. So it is a good treatment. It may work for quite some time, but it's not a permanent cure, which is unlike the hematopoietic stem cell transplantation. So again, both modalities can give you a fairly high percentage. The concern that we just talked about with the IST is the clonal evolution, which is something you don't see in the transplantation. Short-term data, the immunosuppressive therapy is probably going to be better than the transplantation just because you have the toxicity that comes from a transplant, especially if it's not a matched sibling donor. However, with the transplantation, the drop-off in the curve becomes stable after 2 years. So if you can weather the storm and you have no toxicity from the transplantation, after a couple of years, you are pretty much cured of your aplastic anemia. This is not the same outcome that you would get with immunosuppressive therapy. So in conclusion, and when you look at the data, because obviously aplastic anemia is a lot more common in the adult than in the pediatric population, they use 40 and under as the cutoff. So older adults are not going to probably handle the transplantation all too well, whether the younger, obviously, adults and the children are able to tolerate because they don't have end organ dysfunction. So this is the modality of choice. If you don't have a donor, it's not unreasonable to do immunosuppressive therapy. What happens to people that relapse? You have several options. I have treated people in the past with a second round. And there was an old article that showed that the second time sometimes even works better than the first one. So you can try it and you can try a different source. So if you did the equine at the beginning, you can do the rabbit the second time around. But I really think if you're not going to clear your disease, probably a search for a donor becomes very important. And so you look for an unrelated donor. I'm not a fan of using Cytoxan because I don't think it's going to work all too well. So I think this is a rare disorder. When I just looked at the incidence, I think it's almost 5% of childhood ALL. So if you think of ALL as a fairly uncommon disorder in comparison to, say, the adult data. So in the US, there's like 5,000 cases of leukemia in the entire country. So if you have something like this, probably not even 2 cases in the UAE per year. I don't know exactly the data, but I think it would be good to talk to some other colleagues and see how often do we see acquired aplastic anemia in this region. Thank you for your attendance. I'm going to stop at this point and take some questions.